Okay, welcome everyone to our first triage webinar for 2026. My name is Sue Barry. I'm the Primary Care Advancement Manager at Sydney North Health Network. So I would like to introduce our speaker. If you haven't met Wendy before, she's done some wonderful sessions for us last year, and we received great feedback. So we're very pleased to be able to have Wendy back with us. So she's a practice manager and has a long history in general practice spanning 25 years. And she currently works as a practice manager in a large 22 GP practice in Gisborne in Victoria. She mentioned that it's pouring with rain down there, so lucky Victoria. And she's been working as an education consultant since 2017. She's very passionate about general practice and has a thorough understanding of all facets with a special interest in MBS and chronic disease management. While working full-time, Wendy still takes any opportunities to meet and work with new practice managers, guiding them through the complexities of general practice.
Thank you so much, Sue, and welcome everyone. It's lovely to see so many faces or so many numbers here tonight. Tonight's topic is a very relevant one for us in general practice, and it's really important that we allow our staff or encourage our staff to do regular triage training, particularly our non-clinical staff, because triage is such a big part of their role. So tonight we're going to cover off on quite a few topics. We're going to look at the basic principles of triage. So what triage is and how it works within a general practice setting. We're also going to look at how effective appointment management reduces the need or reduces the amount of times we need to triage. We're going to look at how documenting can reduce the clinical risks to your practice. So making sure that we are documenting situations that could become an issue later to ensure that the full encounter is documented while it's fresh in our mind. And we'll also look at the need for adequate policies and procedures to support our non-clinical staff in the triage process, because they are just that. They are non-clinical. They do not have a clinical background, and there are so many new medical receptionists coming into the field who are often young or inexperienced. And as we know, for those who've been in general practice a long time, like me, experience is what triage comes with experience. So the longer you're at it, the better you get, but it is not something that just we're born with. You do need to learn it. And finally, we're going to look at the benefits of having practice-specific tools that can guide the triage process within your practice. So having something that's not a generic pop gun that sits on your receptionist workstation and they look at it and it's not even relevant to your practice. So make it yours. And that's, I think, one of the take homes I'd really like you to leave with tonight. So general practice is often described as the front door of healthcare because it's the first and most common point of contact that patients have with the health system. If they're sick, the first thing they think about is, I'll go and see the doctor. And as non-clinical staff or as general practice staff, we are faced with a varying degree of needs, from the minor issues such as coughs, colds, medical certificates, and referrals, right through to time-critical emergencies such as chest pain or anaphylaxis. We need to constantly juggle the limited availability of appointments that we have, ensuring that we don't overburden our clinical team, but whilst ensuring that patients receive the right care at the right time by the right person. Remembering sometimes the right person may not be us, and we'll talk about that a little bit later. When we describe triage, it's not about refusing patients care or just saying no. It's about prioritization of care and reducing the risk to both patients and our business. Unfortunately, we often find ourselves facing an overdemand and undersupply situation. We don't have enough appointments or we don't have enough doctors. Our appointment books are often heavily booked, if not completely booked, on many days. And this leaves us, unfortunately, having to triage right from the start of the day. Juggling having adequate appointments available without leaving our clinicians underbooked is also a daily challenge which many medical receptionists face. Our GPs want to come and they want to work. They don't want to see a book half empty so that we can make sure we can see people on a day. Performing appropriate triage will ensure we are able to provide appointments for those in need instead of those who call first. Result, result of little or no triage leaves us having to double book, squeeze patients in, which then puts that pressure on our clinical team. They miss lunch breaks, they miss their coffee breaks, they miss their end of day finish, they're working late, and that can lead to burnout in our clinical team. So we have that pressure as well, recognizing that our decisions have an impact on our clinical team. So this is why the process of triage is a team effort. Everyone needs to know their part in the triage process within your practice, and that will ensure that doctors do get their lunch breaks and that reception aren't inundated or overwhelmed with the having to say no to every person. When we perform triage, we are determining the level of urgency. Does the patient need to be seen? And if so, when do they need to be seen? Do they need to be seen now? Do they need to be seen this afternoon? Do they need to be seen tomorrow? We're also looking at risks. So the potential for delayed diagnosis and treatment could have serious implications for our patients. And of course, appropriate pathways. Are we able to help this patient or are there better choices? So, for example, if a patient calls with an embedded foreign body, we might be best just to refer them straight to an optometrist. Or if they have dental pain, refer them to a dentist. Or if they have chest pain, call an ambulance. So we don't have to see everyone, but it's also great to have options available to people. So that's one thing I work closely with my staff, ensuring that they just don't say no. They give them options. Have you tried the urgent care center? Have you tried the doctor, the dentist, the optometrist? So keep that in mind when you are creating your triage tools. Another consideration is that triage is predominantly performed either by phone or when the patient presents to reception. In both cases, prior to seeing the clinician or the doctor. So we have to ensure that the right decision-making tools are available to our non-clinical staff so that they can appropriately triage these patients in to fit the clinical needs of what they're presenting with or what their needs are. Using triage will ensure that patients requiring urgent attention will receive safe, timely, and appropriate care, either by us or at a more appropriate service. But it also allows patients to be guided to a service which better meets their needs, which may be ED or another care provider. So triage at a glance, what does it look like? With the areas we need to consider. Clinical safety. Patients may present with symptoms that could indicate serious conditions such as chest pain, stroke, and triaging ensures that these urgent cases are acted upon promptly. Then we have demand. Often demand exceeds available appointments, so performing appropriate triage allows fair and clinically prioritized allocation of the appointments. And we will talk about that a little bit later. Some issues require the GP or the nurse practitioner or a mental health GP. They could be done by telehealth or they should be referred elsewhere. So there's lots of different opportunities to provide services to patients within your practice. Meeting regulatory and accreditation standards, we do have to meet standards which say that we have methods of identifying patients who require urgent care and that we have availability for patients to be seen if they need to be. Supporting continuity of care, obviously triage helps match, well, I'll get that out in a minute, helps match patients with their regular GP or another care team where appropriate, and efficient workloads. So if we are not double booking our GPs, it reduces wait times. Patients aren't getting cranky because their appointment's at 10 and the GP's had to see a walk-in, so it's now 10:30 and they're still waiting. So all of those things are what we can work with or work towards improving with appropriate good triage skills. So when does triage occur? Triage is not just about those emergency presentations. We are doing or we are performing triage all day, every day, sometimes multiple times for the same patient, depending on whether their condition changes between the time they book the appointment, between or when they arrive or after they arrive. The use of appropriate questions will assist the staff, particularly the non-clinical staff, but also our nurses in guiding the patient to the right care. And triage is a skill that is learned over time, and staff new to general practice will not have the same level of competency as someone who has worked in the industry for many years. So where they have learnt from experience what can be potentially life-threatening. So as I said before, experience does play a big part in the confidence of performing triage. I often like to show this slide because this is an appointment book from a general practice from August in 1983, where the only tool for a medical receptionist was a pencil and a rubber. Now we find reception staff often spend more time telling patients why they can't have an appointment than actually giving them. So what's changed? Why is there so much more demand on general practice on a daily basis? Lots of things, but obviously earlier discharge from hospital. In 1983, if you had surgery, you're in hospital for 2 weeks. Now you're in hospital for a day, sometimes two. So people are being discharged back to our care a lot earlier. Chronic disease prevalence, as we know, the prevalence of chronic disease in general practice is a huge chunk of the care we provide to our patients. Dare I say the word pandemic or outbreak, which we have lived through, so we know what the potential can be for our appointment systems. And primary care is now the forefront of healthcare. More services are being directed to our door. We are the first point of call for many patients. Previously, we had maternal child health nurses who are still around, but mums with sick babies, they don't think of them, they think of the doctor. We're more accessible. If you go to an ED, you could sit for hours waiting for an appointment, whereas patients know if they walk in, they may get a chance of being seen sooner or may have to wait, but they're sure, they're my GP. I've got a great relationship with them. And that's what we've got to remember. Our patients trust us. They have entrusted us with their care. And that's not just about when they're well, it's about when they're not well as well. We have an aging population. As we all know, the population is getting older, so there's more risks, more regular GP appointments are required. There's more risk to those patients. And of course, the biggest problem at the moment is workforce shortage. As you saw earlier, I have 22 GPs and we are still booked out every day. So it doesn't matter how many GPs you have. If you're a 1 GP practice or a 22 GP practice, you are still going to face the same challenges. So I want you to consider the following. Just think about this. Mum rings today at 10 o'clock. It's Monday morning. Let's say Monday morning is your busy, busy day. And she says to the medical receptionist in a frantic voice, my son has a high temperature and a rash on his arms, and I need to see a doctor today. So straight away, what would happen at your clinic? Would you be able to see that patient? Would you refuse care? Would you refer them elsewhere? Would you have an available appointment? The key to these three questions is the last one. What questions might you ask to help you determine exactly how urgent this is? So I'm going to give you an example. So let's put that same scenario back on the table, and I'm going to say to the mum, oh, I'm so sorry to hear that. How old is your son? Oh, he's 45. So in my mind, I'm dealing with a mum with a sick baby. So I'm already triaging that as an urgent presentation, particularly with a rash and a temperature. However, it's now dropped a little bit because the son is actually 45 years old. So that is a really good question to start with to actually understand what you're actually dealing with. The second question you could ask is, how long has he been unwell? So is it something that's presented quickly? Oh, he's been like this for a couple of weeks and we finally decide we need to see a doctor. So that really gets, for all those in general practice, will understand the frustration that occurs when they wait till 6 o'clock on a Friday night to ring where their son's been sick all week to demand an appointment. So if you ask questions, you may be able to determine what's more appropriate for that patient versus, oh my gosh, it's a child with a rash and a fever, they need to come straight down. So questions are very important. We also have to remember perception. So one of the challenges of performing triage is dealing with patients' perception of what is urgent because their perception is often influenced by other factors. It could be that the symptoms that the child or the patient is having are scary to them or they're unusual. They may have had past experience of a significant event that may have been that made them more hypervigilant, particularly if there's a bad outcome previously. We hear about it all the time where the patient wasn't seen and they end up in hospital. So those parents or those patients are going to be more hypervigilant and more insistent. Last time you didn't see me and I end up in hospital. So nothing like adding a bit more pressure, is there? And then they could just be anxious and having difficulty describing the symptoms, or they may be vague and non-specific. That's where questions are so important. If the symptoms are vague or non-specific, how are you going to triage them appropriately? So this can sometimes make the process much more difficult as the symptoms they are describing may not appear urgent to us but will result in the patient feeling that their needs are not being met or that they are being ignored. So remember, perception of what is urgent is a two-way street. Our perception of that's actually not urgent, whereas they are perceiving it to be urgent. So please remember that. Don't dismiss them because it's their perception and we can't change that. When a patient perceives their symptoms to be urgent, it can result in the patient being more demanding and insistent, which can lead to pressure on us to find them appointment, even though the symptoms described are not actually in our list of urgent presentations. So it does put a lot of pressure on the non-clinical staff when they have those demanding, insistent people, I need to see a doctor. It can also have the opposite effect, and the patient may not perceive their symptoms as important and downplay them, whereas we see them as urgent and they are saying, no, I don't need to come in. So it becomes the opposite end of the scale, but just as difficult to convince them that they need to access care. This is why we need clear scripts or supportive tools to help guide how we extract the information to ensure the care is provided appropriate to the clinical needs of the patient. So having those guides to assist our staff to quickly extract the important information will make the triage process much more, much better. The other barriers for patients accessing care, of course, is the ability to retain staff, particularly in rural and remote areas. It's becoming more and more difficult, and not having enough GPs to meet the needs of our community is prevalent in many areas. There's also a clinical risk. The level of experience that your practice staff have does vary. So with experience comes knowledge. However, new staff, particularly if they are new to general practice, often lack that knowledge and therefore are at risk of missing something or not understanding the potential severity of a patient's presenting symptoms, usually as a result of minimal or no triage training or having procedures to follow or to guide them. Then there's a risk, there's always an underlying risk of litigation concerns. As a medical receptionist, if I don't give the patient an appointment and something goes wrong, they're going to sue me. That is very common. It's a very common train of thought for reception staff who feel, I guess, unsupported by the process. That's why we need to make sure that they do feel supported by having the appropriate tools to perform the task. As I said earlier, it's important to understand that we all have a role in triage. It is vital that we understand that as non-clinical staff, your job is not to diagnose. You are not to determine whether that patient is sick or not well. Your role is to determine using your guidelines whether they need care and if so, when. Your role is to gather information using a structured and consistent set of questions and being able to quickly extract information which is relevant to allow the clinical team to take over the triage and determine the level of urgency. However, the triage process can be delayed when the patient does not want to give you the information about why the appointment is required. There are a lot of people who will not share information with you. I can't count the number of times we've had a patient who's booked an appointment, sat in the waiting room for 15 minutes, gone into the doctor and said, what can I do for you? Oh, I've just been having chest pain for 12 hours. So patients often don't want to tell because they know we're going to tell them to call an ambulance. So they sneak in through, and it's not till they get to the GP or to the nurses do they let us know that they're actually having chest pain. So we deal with so much every day, don't we? So I have touched on this before, and I will reiterate this. Staff need to know what their role is within the triage process and at what point they should hand over a patient to a clinical team member. So, as a receptionist, when do you decide that I have gone as far as I can with this? I now need to refer this to the nurses for more in depth or more appropriate triage. Again, having a clear policy to guide them will ensure the roles are not blurred and patients are dealt with appropriately. There's nothing more frustrating for a patient who gives the whole spiel to reception and then are put through to the nurses, and the nurses, yes, what can I do for you? And they've got to start all over again. So that really good handover is also important. And that's where those skills of quickly extracting information to hand over to the clinical staff is really important. We also need to consider the location of the patient. Are we the closest service, or is there something between us and them that would be more appropriate to them, potentially an ED or another service? Consideration around what other service may be suitable, and we talked about that before. Foreign body in the eye, send them to an optometrist. A toothache, send them to a dentist. Knowing when to seek support from the clinical team is vital to all the non-clinical team people here tonight. And you should feel supported by each other. You should have confidence that when you pick up that phone or pop around to the nurse's station to ask them to help you, that they will step in knowing that you have reached the limits of your triage capabilities. Non-clinical staff should never, ever offer clinical advice. For example, take a Panadol and lay down, or have you tried taking aspirin and lay down for your headache? We haven't got any appointments, but maybe you could go to the chemist to get something. Never. You never speak about treatment or diagnosing. You basically extract the information. If you've got an appointment, obviously you're going to give it to them. If not, you then need to put that call through to the clinical staff if you believe that this is something that needs to be dealt with. And you will learn as time goes by. So, when you're asking questions, I said before that patients are not often willing to tell us why they're coming. So, in order for us to appropriately triage, we need to know what the presenting symptoms are. So, we need to know if the patient refuses to answer, you could say something like, that's okay, I don't need your private details. I just need a general idea so I can make sure we schedule your appointment correctly and safely. Or if they're still saying, no, that's none of your business, I'm not going to tell you, or no, I'm not, yeah. You say, look, I'm sorry, sir or madam, but without knowing the reason, I can only offer you the next routine appointment. If your concerns become urgent, please let us know so we can reassess. That often prompts them to say, well, look, I'm having this, I'm having that. So but calm, clear-headed, and saying to that patient, I don't need to know the ins and outs of why you're coming. I just need to know a brief description. And then on the other hand, you get the patient who wants to tell you everything. They want to tell you what they had for breakfast and what they had for dinner last night. And you get the whole story where you're sitting there thinking, oh my gosh. So again, one extreme to the other. So let's think about it. I want you just to keep this idea in the back of your head as we move forward. Do you have a triage system in your practice? What guides or policies do you have in place? Where is your triage policy, and when is the last time you saw it? Is it available to you? Do you even know where it is? What is it? do you just book appointments? So when you're making appointments, do you just open the phones at whatever, turn them over at whatever time you open, and just book, 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 book until there's nothing left? Or do you spend that time trying to triage patients who don't need to be seen today to a future appointment to ensure that you can still have some available appointments? Do you keep adequate appointments? Are you fully booked before you start the day? Or do you have appointments kept so that patients can call on the day? So they're the kind of things I want you to mull over while we move on. We'll touch briefly on what this standard state, because I did mention that it is an RACGP accreditation requirement that we have triage processes. So the standards state that we must document incidents where we have triaged a patient to substantiate the information provided during that course of triage. Now, what do I mean by that? What I mean is you must document. So if a patient is triaged and either refuses care or hangs up or decides to go somewhere else, documenting what you said is really important because the patient will only remember you saying no. They won't hear anything else. So try to ensure that when you are recording discussions, it doesn't have to be an essay, just a brief description. And I have got a contact sheet that I'm going to show you shortly on where or how you could potentially record these. And you only record the ones that you think could become an issue. So by recording that, it reduces the risks of medico-legal action because you are not going to remember that conversation in a week, in a month, in a year. You will not even remember having that call. Whereas if you have documented it, what you said and what the patient said and how you finished the conversation will be documented. And the most appropriate and safest way to finish any conversation with a patient is to end with a disclaimer. What does that mean? I have booked an appointment at 2 p.m. today. However, if anything changes or you feel concerned in any way, please call back. Please call us back and we'll see what we can do. You have then taken the word no away and said, okay, I'm going to book you an appointment for later today, but we do care. And if things get worse, please call us back and we'll try our best to do something better. So it shows the patient that yes, they have you've been given options and they feel that that their concerns have been validated. So very important to do that. If you're not doing that, please do it because the last thing the patients hear will be you saying, call us back if you need us, and not no. If your practice is accredited, you are required to have a triage policy. And I do want all of the non-clinical people here tonight to go to work tomorrow. And if you don't know where your triage policy is, ask your practice manager where so that you can look at it. Your policy, your practice policy determines when and how people are seen and what is urgent and what is not urgent. And it must be practice specific. And we'll talk about this regularly soon because this is really important. As I said, if you have a generic triage tool at your front reception and it is not relevant to the types of patients you see, it is a waste of time. You should also ensure that that the when you when you my mind, sorry, when you prepare your triage tool, that all staff have input into it. Your policy should be created by your team and it should include the following: when and how to seek medical treatment. So what is important, what's not, and what's in the middle, how the practices manages people with urgent needs, and what to do when the clinical staff are not available. Now that can happen. This happens for many reasons. The clinical staff might have an emergency they're dealing with. They may be staff shortages and two of the nurses have called in sick and the other nurse is run off her feet, or the one nurse that you have normally is off and there is no one to assist you. What are you going to do in that situation? So that is something to consider when you are creating your triage policy. There are standards also state in 1.1b. Now, yes, this is the fifth edition. I know the sixth edition is coming, but the process of triage and determining urgency is not going to change. So you must as I said before, one of the standards is retaining evidence, and that's what I was talking about with your evidence of phone encounters, or it could be face-to-face encounters that you've documented. If you have access to the patient's clinical file, it is worth documenting it in there, although many medical receptionists don't. So this is where the other resource that I'm going to show you so shortly will come in handy. So have triage guidelines. So what can you do? You can have triage guidelines. I'd say if you were to be accredited tomorrow and you had these things here, you would be fine. Have a triage guideline at the reception area. So not hidden under 45 different bits of paper or stuck on the wall, which is hidden where 45 other things have been stuck on top of it. Clearly visible for reception and the nursing team. Have that flow chart available, accessible, and easy to understand. Display a sign in the waiting room. It could be something like, "Dear patient, if you feel your symptoms are, that your health, your condition is deteriorating, or you're feeling, more unwell than when you arrived, please present back at reception for advice." So, put signs around your waiting room to let people know, hey, you can come back and see us if you're not feeling well, and show evidence that administrative staff members update the patient waiting list if there's been an emergency. So what do we mean by that? Do you, when an emergency comes in, do you just say, okay, it's 12 o'clock, the doctor's starting again at 12:30, and he's going to be at least an hour. Do you start contacting those patients that are coming at 12:30 and put them off? Particularly, which means the doctor might actually then get a lunch break, or do you just let them come and make them sit and wait? So think about that as well. Because this is all about triage. Remember, I said at the start that we are triaging all day. Your triage process will start again if there is an emergency and the doctor is held up. You will then have to look at who's coming and determine whether they do need to be seen today. There could be some routine patients that were booked in 3 weeks ago. They just need a script or just want something that may be able to be put off till tomorrow. So triage process starts all over again in the event of emergency. And the final one is that it talks about our phone message saying, if this is an emergency, please hang up and call 000. They never do they? They just wait. Um, the practice team needs to be able to identify patients, so that whole process of triage, and that we are able to triage quickly, and that the needs of our patients with urgent needs are met quickly and safely. So that is the standards per se. Oh, one more, education. So tonight counts, providing education for our non-clinical staff. Particularly, clinical staff have a clinical background, so they are not required to undergo triage. However, non-clinical staff should have triage training at least once in the 3-year accreditation cycle, and that it's appropriate to the patient population, and that you can provide evidence. So I know the lovely team at the PHM will send you out your certificates. So keep those in your evidence folder to show that your staff have attended for accreditation purposes. And finally, as I was talking about before, this is the the sheet I was talking about, the contact sheet. It can be something really simple like this. It can be even simpler than that. But this is what we use, and the reception staff often just print a label and stick it on, and quickly document what they did, what was said, and what was the result of it. Did the patient hang up and not refuse to come? Did the patient decline an appointment that you offered? Did they go to hospital? So make sure you just document quickly. Remember, not for every single person you say no to or that you turn away, but for those patients that you are concerned about their safety and that they are not listening or taking your advice. So let's get on to the policy. This is very important. So to create your policy, you must involve the whole team. It's no point the practice manager sitting in his or her office and writing it on behalf of everyone. The practice manager needs to get input from the clinical team, doctors, nurses, but the most important person to get that input from is our non-clinical front of house team members because they see it all. They deal with all the different types of questions and presentations, and they will see a theme or a pattern, or they will recognize what they regularly get asked, and they'll allow that to incorporate those questions into your policy. Ask your practice team to give you some examples of when they've had to triage and bring them along to your meeting so that you can start working through the processes. Your practice needs to discuss and develop a list of what is urgent, what is semi-urgent, what is routine, and what is not urgent, or what can wait for a couple of days or even a week. So that must be documented in your policy. What presentations your practice determines to be urgent, non-urgent, and routine. And then, as part of that policy, you then will develop a series of questions your non-clinical team can ask to quickly extract the relevant information so that you can quickly get a good idea why that patient is coming. The policy should define the roles and responsibilities of everyone. So the GP, the PM, the nurses, and the reception staff, and any other staff you may have with you. Document the procedure from beginning to end. So basically, document from the time the phone is picked up or the patient presents until that patient has been seen what is expected. And of course, regularly review it. So don't use a policy that's 10 years old. Make sure you regularly update your policy. And I do that 1st of July every year. I get my policies out and I update them all. And it's surprising how much changes in 12 months' time. Write your policy in draft format. If it's a PM, get it drafted and then take it back to the team to get their input. Is this readable? Do you understand this? Can you help me? Particularly the clinical team, they might want to add a bit more into that. So give it back to the team, get their input, and then come back. And you know what? This is also a fantastic quality improvement. If you want to look at a quality improvement activity for your practice, this would be a great one because it is recognizing, hey, we don't probably do things as well as we could. Get the team together. Let's get this happening and make it much better. So keep that in mind as well. Whenever we're doing something, we're always looking at what could be a potential quality improvement. Make sure everyone knows where it is. Everyone has to initial it, they've read it, and it should be provided to all new staff, including new doctors. It should be simple, practice specific, and easy to read. Do not make it a 400-page document with big words that someone starts reading and thinking, oh my goodness, and just skips. So make it simple, make it easily to read. It should involve input from all your staff, be reviewed regularly, and particularly if an incident occurs as a result of your triage policy, where the triage process fell down in some way, that is when you would review that, what happened, what can we do to make sure that doesn't happen again? And that set of questions, which we'll talk about after. So, why do we need to triage? We don't have enough appointments, as simple as that. So, let's look at how your appointment system influences access to care. So, does your practice, just as I said before, just keep booking until you're fully booked? Don't ask questions. Don't determine why they're coming. Just, yep, no worries, you need an appointment, 10 o'clock, 11 o'clock, 12 o'clock, bang, 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 bang. All the appointments are gone in 10 minutes. Or do you triage every call when you've got limited appointments to ensure that those patients do need to be seen today, or could they be put off to a less busy day? Funny, isn't it, saying that, a less busy day? But anyway, the importance of asking the right questions to direct the appointment is a making process, regardless of whether you'll do or don't have available appointments. So even if you have nothing, you still need to ask questions to make sure that that patient is not an urgent presentation that does need to be seen. And I'm going to give you a really quick example. 2 nights ago, my junior receptionist took a phone call from one of our very long-term patients who's been coming to our practice for nearly 50 years. This gentleman is 98 years old, and he rang to say he'd had a fall and he'd tore some skin on his arm. And the receptionist buzzed the nurse. The nurse said, no, we're fully booked. He can come in tomorrow. So Fred came in the next morning and he basically had degloved himself from his wrist to his shoulder and was still bleeding. So we end up having to send him to hospital, all because the right questions weren't asked. So that was a big learning curve. And I'm happy to share that because we just don't get it right all the time. So the right questions to determine if she had said to Fred, Fred, how much of your skin did you tear? Is it just a little bit? And he would have said, oh, yeah, my whole arm. Changes things straight away, doesn't it? So that one question could have changed the outcome. So if you're fully booked, what do you do? Do you say, I'm really sorry, but we're unable to assist you as we're booked out? Sorry, can't help you. Or do you double book or squeeze them in? We all know that doctor that we can squeeze a little script in with, or that doctor that's got a double appointment and we know he won't use that, so we'll squeeze someone else in there. Or ask them, do you need to see someone today? Or could I offer you something tomorrow? You'd be surprised how many people say, oh no, tomorrow's fine. I just wanted to make an appointment. So when people ring, they're not necessarily ringing for an appointment today. They're ringing for an appointment. So one of the first questions you could ask is that, do you need to see someone today or could it wait till tomorrow? Or could you perhaps, or would be something, or could I offer you something tomorrow? You might all of a sudden reduce the impact on your appointments because patients don't actually need an appointment today. They just thought about it, so they picked up the phone to ring to make an appointment. Or do you direct them to another service more relevant to their presentation? Asking questions puts the onus on the patient to identify the urgency. So I said to you, do you need to see someone today or could it wait till tomorrow? You could say one or two things. No, oh no, look, it's just a script. I can wait till tomorrow. Or you could say, no, I'm having difficulty breathing or I've cut my hand and it won't stop bleeding. The patient then determines the urgency, not you. It's taking the pressure off you to determine the urgency. They may say no, but go back. Remember what I talked about the patients who underplay things. Oh, yeah, I'm only having chest pain. I've had it for a week. I can wait another day. We don't really want that one either, do we? So keep that in mind. What does a good appointment book look like? In a perfect world, a good appointment system is essential to minimize the need to triage. If you start the day with no appointments, you are going to have to triage every single call. Ensuring you have allocated some appointments is not only an accreditation requirement, but it also allows you to deal with urgent matters to ensure that people will get the care that they need. We need to accommodate for all types of requests. Now, this is where a lot of practices miss the mark. We don't keep double appointments. Now, if you've got someone in crisis that needs to be seen, they are not going to be a 15-minute appointment. So if you're going to keep groups of appointments, keep two together. So you have got the ability to offer someone a long appointment on that day. So keep that in mind when you are booking in your on the days in your system or when you're blocking out appointments to be kept for on the day. And it must be flexible. So you must have different times. Don't book all your on the days. I call them on the days because that's what best practice calls them, but you might know them as something else. But we have on the days spread right through the day, not just in the morning, not just in the afternoon, not just in the evening. They are spread right through the day. And we are flexible with both male and female. If you only have one GP, then that's defunct. But I have 16 male and 16 female and 8 male. Yeah, 6 male. And patients sometimes don't want to see male, they want to see female. So I need to make sure that I have both of those available. There's never enough appointments. No matter how many GPs you have, there is never enough. The other issue is if you have an increased level of absenteeism due to illness, for example, from a pandemic like COVID, if someone gets sick at work, being a medical centre, they can't come to work. So there's periods of isolation, perhaps if they've got diarrhea. Doctors can't work for, I think it's 48 hours after the symptoms stop with any kind of gastric bug. Many patients will not leave, particularly the elderly, until they have made another appointment. Now, we've all know those patients. They're regular patients, and every month they book an appointment. The doctor didn't ask them to. They just will not leave the practice without booking their next appointment. So and then of course, insufficient triage skills leads to non-urgent bookings taking priority, leaving nothing left. So if you could triage every call, You would be surprised at what you will have available on the day. So what can we do? Like I said, it's not a perfect world, but if in a perfect world, reducing routine appointment allocation on your busiest day. What do I mean by that? I mean not booking cervical screening, chronic disease or care plans, ear syringing, childhood immunizations, Implanon on your busy day. Yes, I know every day is busy, but there's usually one day that stands out. Or is it that day where you have the least staff on? So you might only have a couple of doctors on that day. Try to reduce those non-urgent, routine type appointment to other days. That does help. Another opportunity or another possibility is rostering one GP each day to manage phone calls and urgent cases, walk-ins. GPs can fill their day with phone bookings, checking their results, dealing with quick things like a script or a referral. So you can feel a GP may not be suitable for your practice. So please don't think I'm telling you this is going to be the answer, but it does work for us. And it does work if you have someone doing all those really short things, because what's frustrating is you book 15-minute appointments, for example, and the patient only takes 6 or 7 minutes and the GP is sitting there and could have seen someone else. So we don't know why the patient's coming or how long they're going to take. So having that GP available to see those quick things every day is a really good, even just an hour or two, and book them in, at 6-minute appointments to ensure you get your 23, and get the GP to see those patients for those really quick things. As a rule, 70% of appointments should be advance bookings and 30% should be on the day. So if you have 100 appointments for the day, 70 of those should be pre-booked and 30 of those should be left for on the day. And I know it doesn't happen. By the time we get to the day, we might be lucky to have one or two. This is where planning comes into it. All right. So we've talked about policies and processes. Let's talk about the actual thing, triage. Where do we start? Simple. Does the patient need to be seen urgently? Staff need to know what their role is and at what point they should hand over that patient, as I said before. Prioritizing care based on protocol. So if you have the right protocol in place, your reception staff will know what questions to ask and what is determined to be urgent. So you could offer same day appointments. Nurse assessment first. I can get the nurse to see you if she believes that it's, especially for walk-ins. Offer them the nurse. The nurse can quickly assess them and see whether they, get a bit better picture and determine whether they need to be seen. And my nurses regularly do that and turn people away because they don't need to be seen. They're stable, they're okay, and they make an appointment for them for the tomorrow, and the patient leaves satisfied. Could we do telehealth? Does the patient have to come in, or could we get the GP to give them a quick call just to keep them happy because it could be that they do need to come in, but the GP might be able to squeeze in a quick phone call versus having them waiting in the waiting room for, hours and then holding the GP up. Or do they need urgent escalation straight to an ambulance or to the ED department? Again, this is fairly straightforward. What each person's role is. Reception, non-clinical, gathers information and identifies possible red flags. Practice nurses are the ones who provide that clinical triage, the assessment, urgent care if needed, and escalation if needed. So escalating straight to the GP. GPs will make the final decision regarding how urgent it is. So let's put this in perspective. Patient comes in, receptionist identifies red flags. So she puts the patient in for a booking and the nurse takes the patient round and the nurse thinks, okay, this is a bit worried about this patient. It is ultimately going to be the GP who says, yes, this needs to be seen, or no, it's okay, Mr. Smith, you can come back tomorrow and we'll deal with it then. Doesn't always have to be face to face. The practice manager, of course, is the overarching person who makes sure that all these systems are working and that our staff are appropriately trained. So that is a really good way of putting your staff roles into your triage policy. We look at safety rules for reception staff, remembering, and this is important, I had this stuck up on the front desk. If in doubt, You are never to diagnose. You are identifying risks and routing safely. So you're identifying and ensuring that it's routed to the most appropriate appointment time. If in doubt, escalate. Never guess. Always use clear documentation and use calm, confident tone, because if someone rings in a panic and we start panicking, we're going to get nowhere. So remember that. Keep it simple, straightforward, and leave. You leave nothing but that at the front desk for your reception team. It will be a good guide for them. The non-clinical team, of course, communication is very important. And that can include things like explaining to the patients why you are asking more questions. Why do you need to know how old I am? Why do you need to know how many times I've been to the toilet? Explain to them. In order for me to help you, I need to have a better understanding of what it is what's going on with you, so I can make sure that you get appropriate time. Make sure you have transparent expectations. And by that, simply, if a patient walks into my practice and they are determined to be, yes, they do need to be seen, we are more than happy to see you today, Mr. Smith. However, you may have to wait up to 2 hours. And patient will either say, that's ridiculous and walk out, or they'll say, okay, I'll come back in an hour. No, no, you need to stay here, and because it could be 5 minutes, but being transparent about the possibility that it may take a lot longer than what they're thinking. And that accurate note taking to ensure that we protect ourselves and our practice and our patients. And there's an example. Patient reports chest tightness since 9 a.m., feeling dizzy, advised immediate ED triple O called. That is as simple but as clear cut as you can get, and it covers off on everything. With non-clinical triage, the initial contact, patient presents or they arrive. So the patient phones or they arrive at reception. This is where we start the information gathering. You ask a series of structured questions using approved script, and we'll get onto that shortly, what an approved script might look like for your practice or your triage tools or both. Red flag screening. So you need to be aware of what red flags are, and there's a great slide coming up that will help you with that. And you then the staff then compare patient information against their red flag checklist. So the patient tells you what the symptoms are, and the non-clinical staff will then look at the policy or the flow chart or the pop gun or whatever it is that they use, and they will make a decision. If there are no red flags, they will proceed with the standard appointment based on the needs. If there's nothing today, offer them tomorrow. If it's a possible red flag, they will transfer the call to the nurse or ask the nurse to come out and see the patient if they're presented. If it's a clear emergency, obviously they'll be asked to call 000, or we will call 000 for them. And again, going back to that whole thing about documentation, detailed notes added to the record, to the patient's record, or to the appointment booking. And if you're handing over to your clinical staff, making sure it's quick and sufficient, so that the GP knows exactly what they're dealing with. When you're looking at red flags, these are the most common red flags. These are things that if I hear these, I think, okay, my antenna raises. Chest pain, obviously, difficulty breathing, sudden weakness or slurred speech, heavy bleeding, suicidal thoughts, severe abdominal pain, and high fever in infants. These are the things in my practice that we class as needing further evaluation. There's something going on here. We need to take it further. It's a red flag. When you're and this is another good one to have a reception. It could be part of your policy. It's basically red flag recognition. So what they are, what it could be. So saying to someone, if they're having chest pain, heavy tightness or heaviness, it's a possible cardiac event. We're not saying it is, but we have to treat it as such. And this is what they need to do. Difficult breathing could be a possible asthma attack, it could be a pulmonary embolism, or it could be anaphylaxis. So again, these little cheat sheets really do help your non-clinical staff to guide the triage process. It gives them some supporting evidence. These are the principles which I find works brilliantly, and that is basically, are you calling about an urgent problem? Yes or no? And you'll follow that flow chart through. So as you can see, all of these make great sections for your new policy that you're going to write or your new triage process. So you will get a PDF version of this, so you'll be able to use it. And I'm more than happy to send anything that anyone requests in Word if you'd like it. All right, let's get down to it. Prioritization of patients. As we said before, asking questions, is it urgent? Can you give me an indication of the problem? That's the first thing. The second thing is, where is the patient? Are they at home or are they elsewhere? If you get someone who calls with chest pain and you don't get their name or where they are and you lose touch with them or they collapse, you can't do anything. You feel helpless because you don't know who you're talking to and you don't know where they are. Are they home? Are they on their own? Is there someone with them? So it's important that we quickly ascertain, Mr. Smith, you're having chest pain. Okay, where are you? Just check, give me your date of birth first, because I've got 10 Fred Smiths. Great, got you. Are you at home, Mr. Smith? And that's at 22 Crombie Road. Yes, okay. Is there anyone there with you? No, okay. Is there anyone that lives close that we can call to come and sit with you? So quickly get that information so you don't, if you do lose contact, you don't feel completely useless. Ascertaining this nature and severity of the problem by asking something simple like, how long have you had this problem for? Or has it, or is it getting worse? So you've got a high, might have I've got a really bad rash on my arm. Okay. How long have you had that for? Oh, on and off for a couple of years, or it just came up overnight. It's really itchy and I'm feeling like my airways closing over. So again, the rash, 2 years, 2 hours. And then you use your processes. So I'm a nurse by trade. I am a nurse in my many years ago. So I do have that upper hand. So I can guide my reception staff through some training, but they are given basic guidance. They do not get involved in anything clinical because they are not clinical staff. So when you have your non-urgent appointment, what do you do? So in your policy, it's not just about putting a process, it's about, okay, now we know what is urgent and non-urgent. What is the time frame? So non-urgent appointments can be up from 24 hours up to 48 hours, depending on the urgency, and offer patients a cancellation list if you have one. Urgent appointments, however, you will definitely follow your triage processes using the tools to work out, yes, this needs to be seen straight away, this can be seen in a couple of hours, or this can be seen later in the afternoon. Book the appointment and please remember to end with the disclaimer. If a patient is urgent, these are the recommended actions I would include in my policy: calling an ambulance, directing them to ED. Then it could be that you discuss the problem with a GP or nurse if it's not urgent. Discuss with a GP, urgently. If it is, advise the patient to come in the practice and let the clinical staff, when they come, make an appointment for today or make an appointment within 24 hours. So as you can see, the lower we get, the less urgent it is. So use this to work within with your processes. Now, this is really important. We talked about handover, and I can't stress how important it is. So look at these examples. A receptionist puts a call to the nurse and says, I've got someone on the phone with a stomach ache, and hangs up. So the nurse is like, okay. So then the nurse has to ask the patient all the questions that the reception staff just asked. Or the reception could say, I have a 25-year-old woman on the phone who says she's had abdominal pain for 3 days, some diarrhea, and has been vomiting. Straight away, the nurse has a much better understanding of what the patient's presenting symptoms are. Again, second example, I have a patient on the phone who's burnt himself. Hang up. Oh, and then you're straight away thinking, oh my gosh, it's a burn. Is it a hot water burn? Is it a oil burn? Is it a motorcycle tailpipe burn? Versus I have an 18-year-old who burned himself all over his legs with boiling water 2 hours ago, or that same 18-year-old who burnt himself on a motorbike exhaust 2 weeks ago. So just by, as you can see, handing over good, quick information quickly allows the nurse to know where she's going with the triage. I say she, I shouldn't say she, he or she, or the nurse. I apologize if I've offended anyone who's a male nurse here tonight. What tools? This is my go-to. This is a Word document and I will send it through for you to have a copy of. So, yes, you are going to get a copy of this, and I want you to promise me that you'll make it your own. So, you will put each category. I find the way we have categorized this is quite general for general practice. I think it would work in anyone's practice. And as you can see at the bottom, there is a phone and a person. So the phone is when the people are calling, and the person is when they are presenting to your practice. So that will give you an indication for your non-clinical staff what to do. What I like about this also, if you look at the top center, the questions are there. The reminders about recording the patient's phone number. Who are they and how old are they? So that's really important. Make it your own. The other reason I like this one is the back of it, because it's got a guide for you. It actually has a scenario, how to manage common scenarios faced by reception. So if you'd like it, I'm more than happy to share it with you. Use it to make it your own, because it really does help your clinical staff to have something that they can visualize. So basically summing up what I just said, make it your own. Make sure all staff have input into your tool, and keep updating it. If we get a new pandemic or a new situation where we are having to change the process we triage, then you need to update your pop gun to ensure that you have got that is included. Now we'll look at the red flags. We hear it all the time: A, B, C, D, E, F, G, Doc, DR, but these are the most common. Choking or having, so if you have these as red flags and familiarize your non-clinical staff with these things, it will give them a really good place to start. So it allow them to say, wow, okay, they're choking or having problems swallowing. That's a red flag. They're having problems breathing, red flag. It's not difficult. It's quite visual. So your patient, you can have it in front of you, and your reception staff will feel that they've got something to use as a guide. There are other red flags which are really important. For anyone who doesn't know what that picture is, it's a child with measles. So if you saw someone like that walking into your practice, you would be rushing them back out the front door. So we don't want measles in our practice. So there are other red flags. I've just recently returned from overseas. Yes, we did really focus on that during COVID, but there are outbreaks all over the world all the time. So determining whether there's been any overseas travel recently will help. How old are they? Because we do have to make sure the very elderly and the very young are taken seriously. Do they have any allergies? Abdominal pain is not something to be dismissed. And then there's things like burns, eye injuries, flu, measles, and then of course our ad risk. So again, another list that you can use for your reception or non-clinical team to guide them. This one's really good as well. I really like this one. It's really straight and to the point. Pain, pressure, or tightness in one or more of these areas. Now remember, we don't all present crushing chest pain right up into our jaw, and obviously women do present differently to men. So having something as simple as this can save someone's life. So something visual like that works really well. Your staff, non-clinical staff could say, okay, you're having chest tightness. Could you please describe the pain? Oh, I don't know. Is it heavy? Is it sharp? And get them to describe it in their own words. Yeah, my arms aching and my shoulders or between my back and my neck. So they are classic symptoms of a cardiac event. However, they could also have been out in the garden like yesterday digging up a storm and have strained a lot of muscles. So our job as non-clinical is to quickly just get that information. Stroke, obviously one of the most time-sensitive conditions. This is something you could ask the patient. When the person says, look, my husband's face is all droopy, you can ask them, can he raise his arms? Is his speech clear? Does he seem confused? Bang, straight away, this is where you would call an ambulance. So this is a really good one for those non-clinical staff to learn the symptoms of stroke and how quick action can save someone's life or change the outcome, I should say. So, summing up, triage best practice involves the following: a practice specific policy that clearly outlines the steps in the triage process and the roles and responsibilities of all, not just the non-clinical. GPs, you need to know your role in this process. Nurses, you need to know if your non-clinical staff are buzzing you because they want your support, that they're not doing it to annoy you. They actually need your support. I often hear my nurses get frustrated because the girls will go around and ask the patient, oh. I say, look, they're not clinical. Their job is to give you the information. Your job is to take that phone call. Yes, I know it's not always ideal, but the more we train our staff and the more support we give them, the better they will become. Your triage processes should be practice specific, included on induction and orientation for all new staff, and regularly reviewed. So 12 monthly training, minimum of 3 years, no more, no less than 3 years. So if you're not doing it every 3 years, you need to. Include as risk management. So put that in your risk management. And remember also a quality improvement if you're going to start this process. Having adequate appointments to accommodate urgent. So making sure you have something left so that you can accommodate those urgent and start triaging all the time now when patients are ringing. It involves an algorithm or flowchart, such as what I showed you before, to help guide our non-clinical staff decision making. They need to be able to easily identify red flags and what actions they should take as a result of those. Team-based, a protocol for patients who present with potential communicable diseases. So do you isolate? What processes do you have to make sure that your whole practice is not exposed to measles? And of course, appropriate triage training, which I'm hoping you would have got tonight. And finally, it is an essential skill for all practice staff. By following your policy and your practice policy and the triage guidelines available to you, it will ensure your decisions are made with the best possible outcomes for your patients, but also ensure that you don't feel that you have got to go home and worry about, did I turn away that patient? Is something going to happen? So that's always something to keep in mind. This will ensure patients receive access to care in a timely manner. And I guess the last one is really the most important. Ensures everyone is seen in the right place at the right time by the right clinician. So I'm going to stop it here. There's some resources which you can use to have a look at. As I said, you will get a PDF of this presentation. So Sue will be like, do we have any questions? I think triage is one of those skills that we do learn over time. So I'd really love to know how many people here tonight are new to general practice. Even if it's just a quick comment on how long you've been working in general practice, to give me an idea of who we're looking at tonight and what's important to you, I guess. It is a very difficult skill to master and it does take time. So if you feel supported in your practice, you will develop the appropriate skills. But I think always remembering that you have the ability to ask a question. I'm going to pop you on hold. I'm just going to quickly ask the nurse. So I'm going to pop you on hold and check with the doctor. Or I'm going to call you back in a few minutes. Are you at home? Are you okay? These patients appreciate that. They can be super demanding. Can be very difficult for us to work to do this process, and not everyone is as kind as a lot of patients who will be, okay, no problems, I'll come back tomorrow. I think the most difficult ones are the patients who present at the front desk and will not take no for an answer. I need to get it's just a script. It takes 2 minutes. It can be very frustrating for all of us. So I hope you've learned some skills tonight that will help you to feel more empowered and to give you lots to think about.
Wendy, we do have
Yes.
a couple of questions now. So,
Oh, wonderful.
yeah, great. From Amanda, if there is difficulty communicating with patients on the phone and we cannot resolve the issues, is there a common next step other than calling them back?
Thank you, Amanda. A good question. So when you say difficulty communicating, are we talking a language barrier? Or are we or is it just difficult for them to understand? If it's a language barrier, then definitely trying to get a family member. That's what's really important when we're doing our patients' demographics, that we highlight patients who are of that have got poor English or not non-English backgrounds and have a next of kin or someone mentioned that we can call in that case. It may be that the patient is a different nationality, and you may have a GP or a staff member that does speak the same language or is from the same, ethnicity. So you may be able to get. I'm just sort of throwing some ideas out there. You may be able to get one of the other staff members to call back that may be able to actually understand. Did we get an answer to that question, Sue?
Amanda's coming back. Yeah, sometimes language barriers, sometimes reception or the ability to use the phone.
Um,
Yeah, yeah. They were the language, they were the barriers.
yeah.
Yep.
So reception's inability to use the phone.
No, the patient, I would imagine.
Ah,
Yeah,
got it. Yeah, got it. Thank you. Yes, I would call them back. So, um, get some information together. I guess it also depends on why they're calling. If they're calling about something that you think could be urgent, I would be transferring the call to the nurse and getting them to call them back, particularly if they're using language you don't understand. But the first thing is to determine urgency first. So make sure that they're okay to be called back and then get their number, check our phones display their number, write the number down, call them back once when you have the clinical team member involved.
Mhm. Okay, so Christina has just commented that she's been working 3 years in general practice. She's an RN. Thank
Thank
you.
you, Christina.
And also just a comment that she there's difficulty with NESB and need to take extra time to assess. Do we know what NESB is?
No idea.
Explain that. Sorry, Christina, if you wouldn't mind just elaborating on what NESB is in the chat. We'll just go on. Thanks, Savita. Excellent information. She's been working as a GP for the last 19 years. Christina always checks emergency contacts, she said. I guess that's it.
Very good. Well
Your
done,
callback.
Christina.
Yep,
Yep.
yep, that's good. And also to somebody else said, if it is a psychiatric emergency like suicidal thoughts, what's the best action to take or advice to the patient?
Very good question. So obviously that is not, if you are a non-clinical, are we talking if it's a non-clinical, straight away it goes through to the clinical team. Okay. Now, this is where it's important that your practice is up-to-date resources. Health Pathways is a really good place to start, but looking for urgent care centres, mental health, there's lots of mental health urgent cares popping up, but having resources, a list of resources that you can refer patients to is really important, particularly around mental health and crises. So you don't want to be running through the phone book or on the internet trying to find a local mental health support service. So I would get the triage, the ACAT teams from any of your mental health big services like the hospitals and find out what their process is and have that information available to then tell the patient or for the GP to ring and say, look, I'm really worried about this patient. We need them to be admitted now.
Mhm. The answer to what NESB is, non-English speaking back.
Speaking background. Got it. Yeah, I agree. It's very difficult sometimes it's really difficult to get clear information from patients who don't speak English. Um, do you involve the interpreter service with those conversations? I would think,
Mm. I guess that would be, yeah, ideal, but at the point in time, you have to always organize an
mm,
interpreter ahead of time. So if a
yeah,
patient
true. It's
calls,
also, yeah, it's
yeah, it's
very,
a hard one. If anyone else has got any suggestions that they can share in the chat, that would be great, or in the Q&A. But yes, it is a difficult one.
yeah,
Yes. But yeah,
especially when you're trying to determine why they're coming and you can't understand them.
yeah, an interpreter with care plans is what Christina's saying. Yeah.
Yep, good idea.
All right. I think that just about, I'll just wait another couple of seconds to see if there are any more questions or comments. But you've done a great job, Wendy. Thank you so much.
Thank you. You're welcome. It was lovely
You.
to, it was, thoroughly enjoy this topic because it's really, I guess it's one of those things that's close to my heart because I want to make sure that my team are supported, but then my patients get care when they need it. So, a lot of heads rolled over the Fred Smith with the degloved arm, let me tell you. So it's not, but we're all human. It's easy to make a mistake, and that's why I guess another thing, you are only human. You can make mistakes, but this is why you never make judgment calls, particularly non-clinical. Even clinical teams will make mistakes, but they have medical indemnity insurance to protect them. So keep that in mind also that you are governed. That's probably something worth knowing to all the non-clinical staff. If you follow the practice policies, so the policies and procedures of your practice, you are covered by their medical indemnity insurance. If, however, you go rogue and start telling patients advice and making decisions, you are not covered by the clinical. So that's why documentation is really important to document what you actually said versus what the patient said you said.
Thank you. Thanks very much.